All right, everyone, good morning. Thank you so much for joining us. My name is Angie Sanchez. I am Odawa and Ojibwe. I am a PhD student at Michigan State University in the Department of Geography, Environment, and Spatial Sciences, and my research focuses on increasing access to breastfeeding support resources in Indigenous communities. So as a part of that work, I applied for a grant and was awarded that grant from the Michigan Health Endowment Fund to do a few things. And this is one of those few things that we are doing with the grant. So um, I have connected with the Indigenous Lactation Counselor Training Program, and that is run by Cami Goldhammer and her breast friend, Kim Salas.
It's
And
never get told.
I know, I love it. And anyway, they're two awesome human beings, and this is the work that they do. They're both IBCLCs. And so we, in doing our trainings, which are for Indigenous people and Indigenous communities, we get a lot of requests from non-Indigenous people for, if they can take the trainings, but the trainings are not cultural competency trainings. They are trainings to teach Indigenous people how to, gives them the foundational lactation education that they need to counsel their own community members. So in response to that, I decided to do some extra work and to try to get some trainings going for non-Indigenous people, healthcare workers in particular, healthcare providers, other IBCLCs, even doctors, pediatricians, nurses, anybody that does healthcare, home visitors, other folks that do work with Indigenous communities that are not able to take the 45-hour training that Kim and Cami do. So that's what this is, the result of that. So we are doing a total of 9 webinars over the course of yesterday, today, and tomorrow. So please feel free to share this with your networks if you know other folks that could benefit from this information. The Nooni Project is the name of the project, and our website is nooniproject.com, and you can find all the information there. So with that being said, I'm going to pass the mics over to Kim and Cami and let them introduce themselves, and then they are going to do their presentation today, which is on substances in milk. And then, and we also, if you have questions, feel free to use the Q&A to post your questions along the way. All right, thanks. Good morning.
Good morning. My name is Kimberly Morsalis. I am Dene. I am originally from Arizona, born in Tuba City on the Navajo Reservation. I'm a lactation consultant, been doing this work for over 12 years. 10 of those years was hospital-based lactation. Started in the WIC program in 2009 and certified shortly after. Met Cami in 2014, so she and I have been doing some work together, but we started doing the Indigenous Breastfeeding Counselor course training in 2017. Currently, I do community lactation work where I now reside in Northern California, Humboldt County, which is the Hoopa, Yurok, and Karut people. And and I've been there for almost a year, and now I'm doing this with Cami and other projects. So thank you for having us.
Well, good morning, my relatives. I'm Cami Goldhammer. I'm Sisseton Wahpeton. I'm from South Dakota and live in Seattle, which is Duwamish territory. I'm a clinical social worker, lactation consultant, and full spectrum Indigenous doula, and really happy to be here today. So thanks for having us. Our first session this morning is on substances and medications and a parent's milk. And so we're just gonna go ahead and get started with this. This can sometimes go over on time. So I want to get going because I don't believe in time. So anyway, so we'll just get going. But I appreciate you all being here with us this morning. And please feel free to ask any questions that you might have, or specific things that you might have. So the first thing that I wanted to kind of go over is, because we're going to talk about a lot about different medications and substances that a lactating parent might take, or use, but it's pretty difficult to separate that conversation from mental illness, especially because um, a a majority of lactating people who take medications, the medications they are taking are going to be for mental health. And so this is not going to be a super in-depth presentation on mental health or anything like that, but just more of an overview on where we stand when it comes to mental health in the Native community, and how this relates to breastfeeding. Because a lot of times, and I came into the field of lactation as a mental health therapist, and I will tell you, like the mental health community, particularly around perinatal mood disorders and the lactation community, we sometimes don't see eye to eye, and a lot of times the breastfeeding community and the perceived pressure to breastfeeding is often, um, for lack of a better word, blamed for the mental health state of postpartum people and pregnant people. Um, and so it is, something that's really important. But I will say that the solution to a mental health issue is not quitting breastfeeding. We have to take into account like the whole picture and the whole family and what their goals are. And in some cases, it is. And I have certainly counseled and helped people to stop breastfeeding to protect their mental health. And a lot of times, if we just put in the extra work and do solid research and meet a family where they're at, they can actually have their mental health treated in a good way and continue to breastfeed and meet their breastfeeding goals. And so those two things are not mutually exclusive. Um, but a little bit about where we stand, and I do want to just acknowledge the gendered language that's used here, because this is the language that's used in the research that's done. They're not looking at folks that are non-binary or two-spirit or don't identify as women, but are having babies. So this is kind of why I have specifically say women here. So compared with non-Native women, Native women experience higher rates of alcohol use disorders, anxiety disorders, and anxiety and depression comorbidity. Of people, Native women who have or experience mental illness, about a third of them experience drug use disorders. About 2/3 of that group, 65%, experience drug and alcohol use disorders, so comorbidity there. Almost half experience mood disorders. About again 2/3, another 60% experience anxiety disorders, and then about 30% have been diagnosed with PTSD. Again, this is of people that experience mental illness, so this is not Native people or Native women as a whole, as 100% of the percentage that experience mental illness. This is kind of the breakdown of what that is. So as you can see, there's a lot of comorbidity, which means that someone has more than one mental illness or something going on, right? Among Native women, the incidence of a perinatal mood disorder is around 1/4, and that is thought to be a very underrepresented value. We think that the number is much higher. And as many of you know, it's very difficult to diagnose people with perinatal mood disorders. And particularly when it comes to our Black relatives and Native relatives, it's even harder. We don't have great tools for screening for mental illness or perinatal mood disorders. And the most common one we use is the Edinburgh, which is a 10-question questionnaire that can be done by anybody, right? So it's a self-reported, so people can do it themselves. And most providers will often give it in pregnancy at some point, and then 1 to 2 times postpartum, sometimes more. So the questions, though, however, miss a lot of how perinatal mood disorders manifest in women of color, again, particularly Native and Black women. A lot of the public health messaging around perinatal mood disorders does not often speak uh, to the experiences of Black and Native moms. And you can, some of you have maybe seen commercials for postpartum depression or postpartum anxiety and medication, and it'll be a woman sitting on her couch crying, or in her closet crying, alone, isolated, things like that. And that's just not the experience, or how it often manifests in Native women and Black women. Quite, like, honestly, we don't have time for that. So it is one of those things that it just doesn't come up. We are often doing all the things still and don't have an opportunity to just sit and cry all day. And we often may be surrounded by our families, by our tribe, by our community, going out and doing things. And so again, this is one of those situations that it's really hard to be able to diagnose this or even screen for it. We also, as you saw in the previous statistic, have just a higher rate of things like anxiety and depression in general. And then when we get pregnant and have babies, it's hard to differentiate between, is this different, right? Is this anxiety that this parent has experienced their whole life, starting in their teenage years, different now that they've had a baby? And what is that difference? And that's a lot harder to suss out, and still an area of research that we need to do. So again, just, recognizing that this 25% is probably very, 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 very low. I work in, run a Native doula program at home, and serve Native pregnant moms. And I would say we're probably closer between 50 and
Mhm.
75% of our moms are experiencing
Yeah.
perinatal mood disorders. And Kim's nodding her head
Yeah.
too and saying, the same thing.
Oh, yeah. So, where my mom is from in Talani Lake, it's a very small community. And I actually just talked to her this morning, and just thinking about how hard it is for people in really remote areas to get help and not identify them as
Mhm.
part of the data, right?
Right.
And just how much higher that rate is, and just not getting the help that they need or screening. So that really spoke to me about how it's just not, it's the system's not showing that, and it's hard for them to get
Absolutely.
help. Yeah.
Yeah. And there's so much stigma in
Hmm.
general when it comes to mental illness. And this is across the spectrum. Like, it's
Hmm.
not just the Native or other communities of color. Um, but it is something that, you know, we already, and for folks that kind of got to listen a little bit about historical trauma yesterday and how that manifests in our community. And then we've, in our breastfeeding training,
Hmm.
we go really in depth into historical trauma and unresolved grief as well. But what we know is that Native moms, and I will include Black moms in this,
Hmm.
is we are very afraid to have our children removed from us. We're very afraid to kind of show
Yeah.
any sign that we don't got it, because we are held to a much higher standard than most other people. We don't have the privilege to make the mistakes as parents, or have kind of normal parenting
Hmm.
experiences that is often allotted to white mothers. And so it's, for a lot of Native moms, we can't really show
Hmm.
show that,
Yeah.
because we know that we might be more at risk for losing our children. And statistically, this is true. We are, significantly more likely to lose our children to the system. And so there's just this is really complicated, and there's a lot going on. And again, we're mostly going to be focusing on medications, but hopefully these are little things that kind of can plant seeds in your brains, and you can research more, or we can do more, more presentations some other time. But it's just really something that's important to recognize in our real life lived experiences as Native people and Native parents. And when you're working with Native families, kind of like what might be going on for them. So yeah. All right. So and then, kind of the second one is approximately a quarter of the Native population is affected by mental illness. So again, this includes our Two-Spirit and our male relatives, Native relatives. So we, also think it is severely underreported. And we even do a worse job at screening for and diagnosing mental illness in men than we do women. And so there's just a lot of room to grow here. And someday I hope we get there. So thinking about breastfeeding and where it fits in, because a lot of times, it's like I said, folks will think like, oh, just stop breastfeeding, or what does breastfeeding have to do with mental illness, or we can just, yeah, just stop and it'll be fine.
Yeah.
And that's just not the case, because bottom line is most people want to breastfeed. So about in the Native community, just under 80% of us choose to breastfeed when we have our baby. So it's about 75%. So most of us want to breastfeed, and about 60% of the population does not meet their breastfeeding goals. And so this is a problem, and this is something that needs to be addressed. We can have both. We just need the support. So people with nipple pain have higher rates of depression than people without pain, and this is something that's important to recognize. So breastfeeding is protective against mental health disorders, particularly perinatal mood disorders. And just a quick definition, because I realize I've been using the term perinatal mood disorders without really defining it. So perinatal mood disorders include any mental illness that is a result or occurs in pregnancy and up to 1 year postpartum. And so it's, and we used to, when I first started doing this work, it was just called like postpartum depression, because that's what we kind of thought it was, is it happened postpartum and it was depression. And that was kind of it. There was also like postpartum psychoses, which was the stuff that made the news. And what a lot of people kind of the general population started to be like, well, that's postpartum depression. And again, that kind of further increased that stigma around mental illness and silenced people who were having problems and having challenges, because they didn't want to be associated with women that were experiencing postpartum psychoses and killed their children, right? But that was kind of those became the faces of perinatal mood disorders, which is so incredibly rare. I've worked with thousands of moms over my 15 years as a mental health professional and working with moms and babies. And I've seen postpartum psychosis maybe 3 times. And so it is, it's something that's so rare, but perinatal mood disorders, we see a lot more. So again, when I first kind of started doing this work, we talked, excuse me, about postpartum depression, and kind of only postpartum depression. That expanded to kind of postpartum depression and anxiety, and maybe OCD, which is a form of anxiety. And then now we call it perinatal mood disorders, to be more inclusive of the experiences, and quite frankly, that most people that experience postpartum depression, anxiety, OCD had symptoms in pregnancy. And so we've started screening for people in pregnancy, which is really important, which is why we call it perinatal mood disorders now. So breastfeeding is protective against perinatal mood disorders. But breastfeeding pain or breastfeeding problems is a risk factor for perinatal mood disorder. So again, the solution to a breastfeeding problem is not to quit breastfeeding, it's to treat the breastfeeding problem and address the issue. So again, people with nipple pain had higher rates of depression than people without pain. Mood returned to normal once the pain was resolved. And if you were with us at all yesterday, you know now that pain is not a normal part of breastfeeding. It's a common experience when it comes to breastfeeding, but it's not normal. Pain is our body's way of telling us something is wrong. And we would not ignore pain unless we're like a sadist, I guess. Like, we would not ignore pain in any other part of our body, right? So, but for some reason, when it comes to breastfeeding pain, we as a society have really normalized it, and people expect to experience it. And so they don't reach out for help because they're told it just gets better. And for most people, it doesn't just get better. They quit well before it gets better. So we have to address the breastfeeding challenge when someone is experiencing pain, and that is protective of their mood, right? So that's an important piece of it. People with severe breastfeeding pain, day 1, week 1, and week 2 are significantly more likely to be depressed at 2 months postpartum. So again, just more evidence to say that we need to address this. We cannot ignore breastfeeding pain in people. And as providers, it's our responsibility, because we are often the ones that people, or you are, I'm not a provider in that way. If you're a doctor, a family's OB or midwife or nurse or the pediatrician, like, you're going to be the ones that are hearing from families that this is happening, right? That they're experiencing breastfeeding pain, that breastfeeding is hard, and it is in your patient's best interest, whether that is the mom or the baby, to treat this and make sure that she gets the support she needs. Okay. Breastfeeding support was protective of mental health for people experiencing pain. So again, refer them, learn more about breastfeeding, figure out ways to help people, find a local lactation consultant or supporter. But it is important, and it is your responsibility. And if you had a patient coming to you with any other ailment that was out of your scope or out of your knowledge base, you would refer them to someone to help with that. You would not tell them, like, just stop doing the thing that's bothering you. So yeah.
I have a question.
Yes.
I think I asked of this. Why is it that nipple pain is caused to, like, how is that respect? Yeah.
Yeah. So we don't totally know,
Mhm.
like, why, what it is. I know you've worked with
Yeah.
lots of people in
Mhm.
pain,
Mhm.
and so when you are experiencing pain, um, it's hard. It's hard. You can think of like other injuries. Like, I
Mhm.
know, like, I broke my toe when I was doing CrossFit and couldn't work out for like 6 weeks, and it was a bummer. Like,
Yeah.
I
Yeah.
felt crappy, because I was like, couldn't do my normal things. I couldn't function. I
Mhm.
felt unhealthy, like that kind of stuff. Right.
Mhm.
Um, and a lot of people who experience injuries,
Mhm.
my husband's an ultra
Mhm.
runner, and when
Mhm.
he gets injured, which is all the time because he's an ultra runner, but it's like, it's depressing,
When it's
right?
imagery, it's like
Yes,
depressing.
it's
Okay.
depressing. And then on top of that, we know that breastfeeding pain usually is it means that the baby's not latched on well,
Yeah.
right? So this baby is likely going to be fussy. They're likely to not be getting enough milk,
Mhm.
slow gain. And so that's going to kind of further contribute to that depression and that feeling of those insecurities
Mhm.
and feelings of that as a mom, I'm not doing enough,
Yeah.
so there's a lot more that
Yeah.
probably goes into it. And I'm sure, each individual person has their whole
Mhm.
experience with it. But yeah, that's
Okay.
kind of good question. Cool. All right. So thinking about breastfeeding and the impact of breastfeeding on mental health, we said that when breastfeeding is going well, that it's protective of mental health disorders, right? When breastfeeding is not going well, it is a risk factor. It contributes to mental illness. And so this is what we know, is that people who breastfed or chest fed get nearly 1 hour of sleep a night more than formula feeding parents. And this is significant. Sleep plays a big role in our mental health.
Yep.
And, families that are able to get just 1 hour, of sleep extra makes a big difference for them in their life. And some even get more. The reason why breastfeeding parents tend to get more sleep than formula feeding parents is that we often sleep with or near our babies. We just roll over and pop the boob out and put it in the baby's mouth and go back to sleep, and we're not going to have a big discussion on safe sleep at all, right now. And someday, maybe we will, but we know that with a baby sleeping with their lactating parent, that it is extremely low risk. So, it's something that does help. We don't have to get up, go to the kitchen, make a bottle, kind of fully wake up and then go back to sleep. Again, we can just like kind of roll over, put the boob in the baby's mouth and go right back to sleep. And so, it does, in the end, add up to more sleep in the evening, which is, again, really protective of breastfeeding. Research says that 1 4-hour stretch of sleep is extremely protective of mental health. So, it's not uncommon for a breastfed baby to sleep for about 4 hours, somewhere between week 3 and 6, which is pretty solid. Yeah. Yeah. All right. Breastfeeding parents report having nearly twice as much energy as formula feeding parents. So, that's something else that we see, just more energy, more ability to engage, be active in the world, things like that. We know that breastfeeding protects parental mood by lowering stress. Yesterday we talked a fair amount about cortisol, which is our primary stress hormone. That really kind of gets going. Sometimes if we're stressed about food, stressed about feeding our babies, things like that. And oxytocin is our love hormone. That's the hormone that makes our milk flow out of our body. And it's our hormone that makes us feel really warm and fuzzy. And so when we're breastfeeding our babies, we have a flood of oxytocin in our body to eject that milk out of our breasts into our baby's mouth. And then we cycle those high levels of oxytocin between mom and baby throughout that feed for the duration of that feed. And so that's kind of where we see it kind of lowering stress, right? Among parents who both breastfed and bottle fed, they said that breastfeeding decreased negative mood while bottle feeding decreased positive mood. And then depressed chest feeding or breastfeeding parents touched, stroked, and looked at their babies more than depressed non-breastfeeding mothers. And I have definitely seen this kind of firsthand in the different families that I've worked with, is that when they're nursing, like that baby is held really close, they're cuddled, they're skin to skin, and that parent kind of naturally engages with that baby during that feed. And a lot of times if we're bottle feeding, that does not necessarily take place because someone else can feed that baby, and so those are interactions that the parent might not be having with their baby. And then breastfeeding, this kind of goes along with the lowering stress statistic, is that breastfeeding decreases cortisol levels, and sucking provided short-term lessening of that stress response. And so that's something else we see. And I had an experience, a real life experience where this happened with me, where I was downstairs in my basement watching a TV show with my husband, and my girls, their room is upstairs, and we had someone break into our house while we were downstairs, or they kicked in our door. And when I say I flew up the stairs, I literally flew up the stairs. Like I was ready to meet whoever was between me and my babies. And whoever had kicked in the door, like left abruptly. So by the time I got up the stairs, they were gone, probably realizing that we were home, and or were just trying to mess with us and kicking in doors. I don't totally know what was going on. But when I tell you, like, my endorphins and cortisol levels were through the roof, I was wired. Like, my heart was racing for hours afterward, and I was wide awake. I could not go to sleep. And so I was laying in bed. This was probably about 4 hours afterward. And laying in bed, and my husband, of course, is just like snoozing away, like his head hit the pillow and he's out. And I was still just like so wired. And after a couple hours, I hear my JoJo's little feet come across the floor, downstairs, because she was still nursing, and so she'd come to bed, come and get in bed with me. She was probably around 3 at the time, and she got into bed with me and started nursing, and I was out. And so it was really this kind of like real life experience of, prior to that, I was just totally energized, so much cortisol, but then my baby coming downstairs, getting into bed with me, cuddling up and nursing released that oxytocin, and I was able to go to sleep, and I was so happy because I was so tired.
Yeah.
So it was definitely one of those like real life experiences of that happening.
Yeah, I can say that with Annalicia or Mima when I breastfed her after my my deemer
Yeah.
was a little bit more manageable. Um, and I was able to finally get a good, uh rhythm, I guess, with breastfeeding. And I think sleep really, really helped. Like sleeping, like getting on
Yeah.
a schedule with her. Sleeping was like my favorite time down the rocking chair.
Mhm.
It was so nice. And I think that really helped. Again, sleep is so important
Yeah,
for mom in those postpartum days. And I
totally.
think that really helped with my, you know, my mood disorder.
Yeah. 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 And it is, and we can sleep and breastfeed, right? Like
Yep.
those two things, like, and there's ways to work it out. And we need to work with families to find out something that
Yeah.
works for them.
Yeah.
And I know, yeah, we were talking about that because we were talking about your
Yeah.
napping with your girls and how
Yeah.
important that was.
Yep.
And you made sure that they napped so that you can nap with
Yeah.
them,
Yep.
right? And that was an
Yep.
important piece. And we tell parents all the time, like, sleep when the baby sleeps, but don't actually like stress the importance of
Yeah.
sleeping when
Yeah.
right, like
Exactly.
we're not
Because
very
it
good at
doesn't
like
always work out.
really telling them like, hey, this is a really important piece of it.
Yeah.
And getting sleep is a really important part of that self-care that a parent can give themselves.
And that oxytocin definitely
Mhm,
helps kind of bring down those stress levels. Yeah.
totally. Yep. Cool. All right. So just our takeaway with that is that, breastfeeding is an important protection against parental mood disorders, and the risk factors of not breastfeeding should always be taken into consideration when discussing infant feeding. And so, again, a lot of times, and, I'm not meaning this to say anything badly about my fellow therapists, because we do really important work. And what I see a lot is kind of, I actually just had a discussion on with a mental health therapist the other day who was asking me, well, they wanted me to see their client, but in the end, the therapist just said, I think she just needed permission to quit breastfeeding, which is what I gave her. And I was like, okay, cool. Like maybe that is what she needed. But it also sounded like this mom had a serious lack of additional lactation support.
Mm.
She had been triple feeding for 12 weeks at that point, which,
Yeah.
is
Way.
about 10
Yeah.
weeks too long. And,
Totally.
triple feeding, for folks that don't know, is kind of this recommendation that parents may do themselves, or we may recommend if in the case of a low supply, but it's this idea that they should breastfeed pump and then bottle feed that back to the baby. So that's what we call triple feeding. And this is something that is not sustainable long-term for a lactating parent, and should only be done with guidance and follow-up.
Yep.
And too often we have parents that, again, either get on this pattern themselves, and they, get online and they look up something about low supply and they learn about triple feeding and they start doing it themselves without any guidance or any support on how to do it, when to stop, anything like that. Or they're doing it in the NICU or early postpartum, their provider tells them to do it, but then there's zero follow-up afterward. And that's just it's a recipe for disaster. Triple feeding is, for me, I would never recommend it longer than probably 2 weeks. If there's not an improvement, like, there's not going to be an improvement, like, we're going to see it pretty early on, but I'm going to be providing close daily follow-up. I'm going to be checking in with that parent every day to make sure that they're doing okay, that it's sustainable, is it still working, that kind of things. I'm engaging the entire family in that home to make sure that everyone is kind of pulling their weight to support this parent in this endeavor of trying to up a low milk supply. But anyhow, so I had a mental health therapist reach out to me whose client had been triple feeding for over 3 months. And it was just one of those things where, in the end, the therapist was like, I just, gave her permission to stop breastfeeding, which is what I think she wanted. But, this was something that, like, had this been addressed much sooner, we could have maybe protected breastfeeding to some extent. She could have maybe breastfed a quarter of the time and formula fed a quarter of the time, if just at, 2 weeks in, we were like, hey, this is probably not working out. Like, I don't think you're going to get a full supply out of this. Let's redefine your success and redefine what breastfeeding looks like. And you can continue to breastfeed. And you also can, like, not do this insane, like, daily 12 times a day ritual that triple feeding is, that gives, people no room. So anyhow, it's just, just to say again that, like, we do have to consider these, the long-term risk factors, and particularly when it comes to Indigenous families, the things that breastfeeding is protective against, is, heart disease, diabetes, certain cancers, SIDS, respiratory infections, things that Native people are disproportionately impacted by, right? Up to 60% of Native adults and up to 30% of Native children have type 2 diabetes. I mean, this is like an epidemic in our communities. And so we have to consider what, like, when we tell a family to not breastfeed or don't give them permission to breastfeed, we have to think of that whole little Native baby is going to be turning into a whole Native adult, and all of the things that comes along with that. And for a lot of us, and I, see this, I, have done this too, a lot of us, is we're just looking at this person as a baby or this parent as the parent in that moment. And we just have to kind of broaden and look at this family more holistically, and look at the long-term impacts, and also just like the generations to come, right? So did you have anything to say about that?
No,
all right.
perfect.
Cool. Cool. All right. So with that kind of overview, and I thank you for letting me go over that, we're going to talk about medications in parents' milk. So, just a little bit about medications real quick. We're going to start with prescription medication. And these are just the things that I want you all to know about, is the lens that I'm speaking from. Is breastfeeding is important. Treating parents who need help is important. Medications can be important in the treatment of sick parents. And there are very, 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 very few medications that are actually contraindicated for lactation. And most people, the risk of not breastfeeding is greater than the risk of breastfeeding. So, that's something just to keep in mind, and that we have to consider. So, a couple of key points about lactation and medications is that one is we have some really excellent resources out there. I get extremely frustrated, and this happens probably, I'll say 3 to 5 times a week. I have a parent that reaches out who is told they need to stop breastfeeding because they have to take XYZ medication. And it is extremely frustrating to me at quite honestly, the laziness that I'm seeing in providers, because we have excellent resources out there to tell us if something is safe or not safe when it comes to breastfeeding. And it is very easy to just tell a parent that they can't breastfeed, right?
I have a question on that
Yeah.
too. Is it also, do you think it relates to like liability?
It
Like,
does.
like
does.
where
I
they're
do.
like,
Yes.
I'm just gonna
Yeah.
say, nope, you can't breastfeed because
Yes.
I don't want to get in trouble
Yes.
for,
Yes.
okay.
Yeah.
Yeah.
So it in the medical world, we call this like CYA, or cover your ass,
Mhm.
right? And so it's kind of like
Mhm.
a thing. And you'll see this. This is why, like, when you buy tea, at the store, it's like every tea is going to say you can't take it while you're breastfeeding or pregnant. It's just CYA, right? Just liability.
Mhm.
And, for providers, like especially doctors, like they are quite protected, when it comes to liability. You have to have malpractice insurance, pretty solid malpractice insurance.
Mhm.
And we have research that's really solid out there that we can actually tell someone you can breastfeed and take this medication, so it's not that it's not that hard. And again, for folks that weren't here yesterday, I'm not a doctor. I don't work in that space. So I understand that it's really easy for me to say this when I'm not the one who's on the line. But yeah, you just can't tell me that it's okay for someone to have Percocet after a C-section, but not okay for them to have Percocet 6 weeks later after their gallbladder is removed. Like those two things,
Yeah.
I
Yeah.
cannot, are never going to make sense to me. And I just see it as laziness, So yeah, anyway. I want to introduce you all to Hale, and for folks on here, some of you may know of Hale, some of you may not know. In the lactation field, we refer to Hale as just this book. Hale is a person. So Thomas Hale, he's a doctorate he's a doctor and professor of pharmacology and pharmacy. That might be pharmacology. Anyway, he's a pharmacist, and he teaches pharmacists at Texas Tech University, and he runs the Infant Risk Center out of there, and is a wealth of knowledge. Like, he has so much information, and I am so just grateful for how freely he gives it. So they actually have a phone number that you can call if you have a question about a specific medication or a combination of specific medications. And he has staff, a nursing staff, that will go through and research those and talk to him specifically, and they'll give you an answer. Like, this is like straight up Texas stuff. Like, this would not happen anywhere. Like, I just kind of love it, because we might have, look up a medication and it's safe, but that doesn't necessarily mean that that's the same if that person is taking that medication and 5 other medications, right? It's complex. And so Hale is just like a really amazing resource. Every 2 years, Hale puts out his book, Hale's Medications in Mother's Milk. So oftentimes we just refer to it as Hale. So earlier, before we got here, I said, oh, I need to get Hale out of the bins. And Kim's like, I'll grab him, right? Like, it's like this book is just like a person at this point in our life. So anyway, so this is the cover of the 2001, the 2001 book. So it came out in July. Every 2 years it comes out in July. So what Hale has done is that he has created a lactation scale. So many of you, especially those of you that work with pregnant people, are probably familiar with the pregnancy risk medication scale, which, kind of rates medications on a scale of 1 to 5 on how risky it is for someone in pregnancy to take these medications. That's been around for a long time. And so Hale created the lactation risk scale, which utilizes the 1 through 5 rating scale. So it starts with L1, which is considered the safest. These are drugs which have been taken by a large number of breastfeeding parents without any observed increase in the adverse effects in the infant. These are controlled studies in breastfeeding women, or controlled studies in breastfeeding women fail to demonstrate a risk to the infant, and the possibility of harm to the breastfeeding infant is remote, or the product is not orally bioavailable in an infant, right? Because they would get exposed to it through their milk. As you know, because the L1s include controlled studies, which is kind of our gold standard when it comes to research, this is pretty hard to do with pregnant, breastfeeding, and infant people, right? So, we have pretty strict guidelines, which is a result of really unethical research that was done for a very, very, very long time in the United States that targeted largely Black and Indigenous people, and the most vulnerable populations, right? When it came to certain research. And so we don't have a lot of, now there's a lot more rules, and there's a lot more protections against research participants. And so we just don't have a lot of controlled studies when it comes to people who are pregnant, breastfeeding, or babies. And so we don't have a lot of medications that are in this L1 category. There's a handful, but there's not a lot. And that's the reasoning behind that. L2, these are drugs which have been studied in a limited number of breastfeeding people without an increase in adverse effects in the infant, and or the evidence of a demonstrated risk, which is likely to follow use of this medication in breastfeeding women, is remote. So these are considered safer. Again, we don't necessarily have controlled studies happening, but we know that they're probably fine. L3s are considered probably safe. I will tell you, this is where a bulk of medications live. Most all medications live in the L3 category. These are medications where there are no controlled studies in breastfeeding women. However, the risk of untoward effects to a breastfed infant is possible, or controlled studies show only minimal, non-threatening adverse effects. Drugs should only be given if the potential benefit justifies the potential risk to an infant. And again, this is where most medications are, and we still consider this reasonable to continue breastfeeding. L4s are possibly hazardous. These are medications where there is positive evidence of risk to a breastfed infant or to breast milk production, which is really, really important here. Hale is a diehard breastfeeding advocate. He's pretty hardcore. And so he does not recommend any medications that are going to impact the parent's ability to produce milk or to provide milk to her babies. So he actually puts a lot of medications. Marijuana used to be one of them, and we'll actually talk about marijuana pretty soon. But for a long time, he had marijuana as an L5 because it was an illegal drug. And so a parent taking or using an illegal substance puts her at risk of being separated from her child, right, by arrest or jail time or something like that, or child protective services. And so he put it in that L4, L5 category for that reason, not because it was unsafe for the baby, but because it potentially interfered with that baby's ability to access breast milk, which he sees as a essential right of babies. So again, that there's a risk to breast milk production, but the benefits from use in breastfeeding mothers may be acceptable despite the risk to an infant. So, just something to consider. And there's not a lot of drugs that are in this L4 category, but they are not contraindicated. And then we have L5, which is considered hazardous or contraindicated for breastfeeding. These are studies in breastfeeding mothers have demonstrated that there is a significant and documented risk to the infant based on human experiences, or it is a medication that has a high risk of causing significant damage to an infant. So that's kind of the breakdown of these medications. So some of the things that Hale looks at and how this book is used is he is looking at kind of two things. One is, how do these drugs transfer into the milk, or these medications or substances transfer into the milk? One is, do they attain a high concentration of maternal plasma? Plasma is that colorless fluid in the blood in which fat globules are suspended. And so this is an important piece because milk is fatty, babies are fat. And so we know that medications that can, attain these high concentrations in maternal plasma will also attain high concentrations in the milk and the baby. Molecular weight is, which they shorten to mole, is like the abbreviation for molecular weight, but anyway, is a standard measure of how much of something is present. Is there low protein binding? In general, or the general rule is that agents that are minimally protein bound penetrate tissue better than those that are highly protein bound. However, they are excreted faster. And then does this medication pass into the brain easily? Then we're going to also be looking at the baby, right? So we're going to inquire about the infant, always inquire about the infant. How old is this infant? What is their size? What is their stability? This is perhaps the most important criteria to be evaluated prior to using a medication. There's a big difference between a parent who's taking a medication that's maybe an L4. So let's say this is something that like we're really on the fence about, right? Is this a baby that's a 36-weeker in the NICU, right? For another couple of weeks that's not doing that well, that's not super healthy and robust? Or is this a mom that's nursing a 3-year-old and she nurses him every couple days or once a day, maybe for a little bit? This is a big healthy child, and the parent, and a bulk of their diet is not human milk, right? So those are two very different different babies. And so that's what we mean by inquire about that infant and take in each baby into their own consideration, right? Infant age, premature newborn infants are at somewhat greater risk. Older infants are at somewhat lower risk due to their high metabolic capacity. Infant stability, unstable infants with poor GI stability may increase the risk of using certain medications, things like that. Are these pediatric approved drugs? I cannot tell you the number of times that I have had parents reach out to me being told that they can't take a certain medication when that medication is actually approved for like children to take, right? Like it's a pediatric approved drug. And so, always something to think about. Dose versus age, again, kind of that analogy I just gave a few minutes ago around like, is this a newborn? Is this a bigger kid? How much of the medication is the parent going to be taking? How much are they being exposed to it? Things like that. And then does this medication alter the milk production? In general, we want to stay away from any medications that will lower a milk supply, and definitely something that we always want to consider. So yeah.
I'm glad you mentioned that evaluation of the infant, because a lot of times when I get calls, it's usually a hard no from the
Yeah.
pediatrician or doctors, and it's really good that they evaluate the whole
The
picture.
whole
You have
baby,
the baby,
the
the
whole
yep,
family,
yep.
like you need to look at them as like they are not separate. I always say, like, when it comes to breastfeeding, particularly in the first 6 months of an infant's life, is this baby is still a part of her body.
Yep.
Right? Like she is exclusively growing this baby with her body, just as she did in pregnancy. And just like we don't separate, per se, the pregnancy, a wanted pregnancy from a parent, right? They are one. We need to kind of do that same thing for them when they're exclusively breastfeeding. They are still one body,
Yeah.
right? And that parent's body is growing that baby 100% on their own. And so we have to look at that whole holistic picture, and parents deserve to have that and be treated that way. So this is just a list of actually the very few medications that are contraindicated in lactating people. So there is not a lot on this list, right? So most medications are okay to breastfeed. Like I said, most live in that L3 category. And I just have in red here at the bottom, these are two really common medications. So pseudoephedrine and estrogen are kind of are in general contraindicated for breastfeeding. Pseudoephedrine, if it is going to dry up snot, can potentially dry up milk. And so unfortunately, when it comes to having a cold or things like that, breastfeeding people were stuck with things like ibuprofen, neti pots, and tea. So that's kind of what we can do, because most other medications can negatively impact our milk supply, particularly if you have a sensitive supply or a previously low supply. You're even more at risk, of when it comes to using or taking pseudoephedrine. Estrogen, for folks that don't know, and we're not going, super deep into how milk is made or anything like that over the next few days. Actually, maybe we are. Anyway, I don't remember. But but I'm like, now that I say that, maybe we are doing that tomorrow. But anyway, estrogen suppresses milk production. So we have very high levels of estrogen when we're pregnant. And when we have our baby, that estrogen level plummets almost to nothing. In some people, we are practically menopausal after we have our baby. And so again, estrogen suppresses milk production. And so that's why birth control that contains estrogen is contraindicated for breastfeeding. There is some leeway after 6 months of breastfeeding. It is thought that you can take an estrogen containing birth control after milk supply is very, very, very established and the baby is eating additional foods. Estrogen itself is not dangerous for a baby. So it's like an L2, I think. I actually don't even remember what it's rated at, but it's the impact that it can have on breastfeeding that makes it an L5 or contraindicated for breastfeeding. So I'm wondering if somebody wants in the chat, because I think we have a handful of people, if someone wants to just name a medication, and I'm going to kind of show you how this book works. So we can just have someone, and if no one does it, I'll make Kim or Angie or Mark name something. So does someone just want to throw up the name of a medication?
I'll throw one up
Okay.
while we're waiting for people. Tylenol. That's probably easy.
That's too easy. Tylenol's safe with breastfeeding.
Okay.
But a thyroid medication like Synthroid.
Oh, anesthesia. All right. Oh, okay. Yeah. Anesthesia is good. We would need, the way Hale works, Rayanne, is we would need a specific medication, like drug that's used. But I will say, because I actually don't have a part of this in this presentation around anesthesia, because a lot of parents are told that they can't breastfeed after anesthesia. Yeah. They have to pump and dump for 24 hours, 10 days. I mean, I've seen a huge gamut of different things. In general, we know that once the anesthesia is out of the parent's body, then it is safe for them to breastfeed.
Yeah, it's usually when she wakes up, it's pretty much out of her system.
Yeah, when she wakes up, is good to go. And so it's, but the way Hale works is there's a specific medication, but I'll look up, Kim suggested Synthroid.
The thyroid medication.
Yep. So the way Hale works, and again, anyone can buy Hale. It is geared toward pharmacists. And so there's, things like molecular weight and stuff like that I just, kind of skip over because I don't actually know what they mean. But we look it up in the index. We have a whole bunch of medications, all of them that are in here. And so I'm going to go to Synthroid, which I think, is it SI or SY?
SY.
SY,
SY.
SYN.
And
Yeah, the Synthroid. Okay, so it's on page 367. So then I'm going to go to 367.
In the meantime, so with anesthesia
Yeah,
Anastasia,
Anastasia, the Russian
She-
princess.
yeah,
I love her. So if it's just a one night thing with her,
Yep.
then
Yeah.
You're good.
pumped, it's dumped, it's
No, you don't need to
yeah,
do
you don't
that.
need to do
So
that.
pretty much once they're awake, it's out of the system and doesn't
Okay.
pose a risk to the
and
baby.
so what you're presenting right now is for ongoing
Yeah.
medications.
Yeah. Yep. Yeah.
Yeah.
No, thank you for that clarification. So, Synthroid, page 367. So it's going to have on here, it has like the generic term. So it's levothyroxine. And then it has a whole bunch of trade names. So Synthroid is one of the many trade names that it's under. It gives us the category, which is a thyroid supplement. So this is someone that has either has had their thyroid removed or typically thyroid removed. I think I know my mother-in-law used it.
So I used it
Okay,
when I had
Synthroid or
when I had, remember I had Mima and I had it gave me shingles.
yes, yeah,
Not the medication,
Yeah.
but when I was told to take that, they told me I had to stop breastfeeding.
okay, got
Yeah,
it.
and that's
Yeah.
why. But
And it's
that's not the
common
case.
for
Yeah.
people postpartum to have, I'm almost at a point where I feel like everyone should have their thyroid checked
Yeah.
postpartum because pregnancy can just kind of
throw it off.
can throw it
Yeah.
off. And so, yeah, a lot of people can experience it. So problems with their thyroid. So category it's a thyroid supplement. And it is an L1. So super duper safe in general.
I just kept breastfeeding.
Yeah. Yeah.
It's fine.
Because Kim's like that. Yeah. All right. So so that's kind of it has that risk category, the lactation risk category. And then it's going to have a paragraph of a little bit about Synthroid or levothyroxine about what it does. And then it's going to talk about the studies that have, some information on those studies, what they found. And then there's a bunch of pharmacy numbers. So things that, again, I don't need to know. I know a pharmacist would look at these and they would know what PB 99% means, but we don't need to know that. And so, yeah,
Peanut butter.
I don't know. It's 99% peanut butter. All right. And then it'll give us adult concerns. So it says, nervousness, tremor, agitation, weight loss. And then it'll give us the adult dose. And this is a really important piece because a lot of times we might just stop reading at the L1, right? And be like, oh, it's L1. But then we go to adult dose and it's saying 75 to 125 milligrams a day. And so this is something that, you need to consider and think about like how much of a medication are you taking and I've had this happen where I've had folks that, I look at the adult dose and learn that they're taking like 4 times the typical adult dose or something like that. And that L1 rating is based on the average adult dose. And so again, just something to consider. And that would be a reason to maybe call Hale and say like, hey, I have a parent that's taking 350 milligrams, right? Is it still an L1 or how does that work? And then we're going to have the pediatric concerns, of which this says none reported via milk. Infant monitoring is blank because there's nothing to worry about. And alternatives is blank because this is an L1. So you really can't get better than that. Right. So there's not anything there. And then it lists the references. And in this case, we have 3 references where they got their information. So yeah. It's a great one.
Yeah. And I like Hale too, because it's easy to read and understand.
Super easy to read. Yeah. A lot. I actually prefer it over like of Black Med, like some of the apps even. I'm still like old. I'm Gen X and old school. I like to read and look in the book and I'll make copies of these to send to parents. Because again, unless we're a medical provider, so in this case, like we're not, technically medical providers, we we can't really give people advice and say you can or can't take a medication. What I do is I give parents the information they need to make an informed decision.
Yep.
So if they're being told they can't take a medication, or they were told by their provider that they can't take a medication, I'm not necessarily going to say like, that's fine, even though sometimes I'll say that's fine. But I'm also going to provide them with information so that they can make an informed decision.
Yeah.
And they can do what's right for them, because every family has a different level of risk that they're comfortable with,
Yeah.
right?
Yeah.
I live in a household where my husband and I have very different levels of risk. You know, I'm someone that, you tell me I have like a 10% chance of being hit by a car if I run across the street. If it means I don't have to wait any longer, I'm probably going to take that risk, right? Where my husband's like going to be like, no,
Yep.
like I'm going to wait for the crosswalk,
Yeah.
like that's just, he's not
Yeah.
comfortable with that level of risk. So, we all have our different things that we're comfortable with and comfortable for our children.
Also too, if you work, if you're a lactation consultant or a nurse, someone that works with families, and you're having trouble, I mean, I always had the updated version on the unit because it's easy to get to. And then just really working with your people, like your allies, the doctors that's taking care of the baby, the charge nurse, everyone that can support you and helping this mom continue breastfeeding. Sometimes there is pushback, and if you feel like there's no moving forward with mom breastfeeding, make sure she's pumping and protecting her milk supply. So you want to make sure she is doing the things that she needs to do to keep that supply going, but also follow up and again, create that support system in the hospital so that mom can keep breastfeeding and everyone's saying the same thing. You don't want to confuse mom, especially when she goes home. That's a lot of uh, frustrations of parents that they are told one thing and not the other. So we want to say the same thing for families.
Yeah. Yeah. And one thing, I mean, the focus of this presentation is really on medications and substances. So we're going to talk about recreational drugs pretty soon. But I do just want to make a special note around our traditional medicines, because we have medicines that treat a lot of different things. And for that, it's just best to talk to your medicine people, your elders, because they know, right? They know if something's not appropriate for breastfeeding or is appropriate for breastfeeding. And so that's who we should be talking to when it comes to traditional medicines. Hale actually does have some things on herbs in here, but not a lot. So there's they just tend to be common herbs, like fenugreek, things like that, common herbs used for increasing milk production. But he's not going to have, anything on like slippery elm or nettle, or things like that. So just something to consider and make sure that you're talking to the appropriate people in your community about what's safe for breastfeeding and what's not. All right. So, just looking at, our common prescription medications, these are the things that are most commonly used or taken by lactating people. So the first is antidepressants. We talked a little bit about the impact already of depression, anxiety, and perinatal mood disorders when it comes to lactating people. And so for folks that are in need of a prescription medication to help support, or provide them what they need when it comes to their perinatal mood disorders, we have antidepressants, which are the ones that we use are SSRIs. These are selective serotonin reuptake inhibitors. They treat depression by increasing the levels of serotonin in the brain, and serotonin is one of the many neurotransmitters that carry signals between our nerve cells. SSRIs block the reabsorption or that reuptake of serotonin into neurons. And so this just makes more serotonin available is how it works in the brain. So the most common ones, and this is in order of preference, are Zoloft, Paxil, and Celexa. So those tend to be the ones that are going to be like the first line of defense for a parent that has chosen to start taking an antidepressant. These are all medications that we know are considered safe with breastfeeding and are helpful in treating depression. And so that's kind of why they're preferred there. Um, for anxiety, for someone experiencing postpartum anxiety, there are certain SSRIs that also oh, I'm sorry. I just want to go back really quickly, actually, around SSRIs or antidepressants, is that it takes about 4 to 6 weeks for the full effect to occur. And so that's something that can be really frustrating for some parents because there's not a lot of medications that take that long to, take effect, right? I'm sure some of us have the experience of taking like a antibiotic and, you're supposed to take it for 10 days and you take 1 or 2 doses and you feel better already, right? Like that ear infection is practically gone, but you have to take that medication for another week. And so a lot of medications, they start working right away, and just antidepressants are different, or SSRIs are different. They take a longer time to get going, and that can be hard for families. And so it's important that they have that guidance from their doula, their healthcare provider, their lactation consultant, whoever's working with them, to make sure that they know that they're not necessarily going to feel better right away. And it takes some time to build up that medication within the system. So kind of going back to anti-anxiety medications, we have a couple of different options. One is SSRIs. So ones like citrulline, citalopram, fluoxetine. I'm sure I'm butchering how you say those, but these have anti-anxiety activities, so they can be good options, especially when someone is experiencing depressive and anxiety symptoms. So have that comorbidity, which is quite common. So those can be good medications at treating both the depression and the anxiety. We also have options like beta blockers. The most common one, and the one that's safe for breastfeeding, is pranolol. Beta blockers help to reduce the heart rate and slow the body and act really quickly. And they can be taken regularly or as needed. So if a parent, it's not one that has to necessarily be taken daily, the way an antidepressant would maybe need to be taken. And then we have benzodiazepines, or benzos is, what we call it on the street. So these are uh, medications. The most common ones and the ones that are considered safe with breastfeeding are diazepam and lorazepam. So benzodiazepines, they quickly reduce anxiety, but they can take uh, you can't take them long term, sorry, because they are addictive, and they can also accumulate in a breastfed infant, resulting in drowsiness and poor feeding. So again, these are medications that we do have to be really careful with, and a parent that is taking benzodiazepines should be have really close oversight, and we should be thinking about kind of like moving them off of them after shorter term use. Pain medications. These are, really common for breastfeeding parents, especially, just thinking the fact that about 30% of our community of birthing people are delivering via cesarean, and that is a major abdominal surgery, and pain medication is often essential after a cesarean birth, and they are considered safe. And again, this is where I can get really frustrated with doctors because, in general, lactating parents and postpartum parents are told you can go ahead and take this pain medication for a couple of weeks while you recover from surgery. But then 6 weeks later, that same parent needs their gallbladder removed, and they're told by their surgeon that they have to stop breastfeeding or they have to pump and dump or something like that, even though they're just taking the exact same medication. Most pain medications are opiates. And so they do get into the milk, they do get to the baby, but they pose minimal risk, and we certainly want that family to continue breastfeeding. And so just definitely something to keep in mind, especially if you have someone that you're working with that is needing something like surgery, or whatever that is, right? That's going on. So just be aware of the guidance that they might be given by their provider. And then we have mood stabilizers, and mood stabilizers are most commonly used with people who experience or have bipolar depressive disorder. We thankfully have a lot more options when it comes to medications, but lithium had been the tried and true medication for a really long time. Lithium in general is contraindicated for early pregnancy. And so a lot of times parents choose to not take lithium in the second and third trimester, even though it is somewhat sometimes considered safe. But because it's not safe in the first trimester, a lot of parents are a little shy to take it, later on. And so then, they kind of are like, is it okay for me to take when I'm breastfeeding? So it is considered an L3. So, probably safe, but it does require careful supervision, and we need to be monitoring the baby's levels along with that parent's levels. Okay. So the next thing that I wanted to talk about is synthetic opioids. And I know this goes without saying that, our communities, our entire country is experiencing, a epidemic when it comes to opioid dependence. And we have medications now that are being used very successfully to treat the chronic illness that is addiction and opioid dependence. And these medications in a lot of ways are miracle medications, and have allowed a lot of parents to stay with their families and be healthy and sober and live long lives. And so but they often, especially when it comes to the buprenorphines like Subutex, Suboxone, Buprenex, these are thought to be medications that are going to be used lifelong. And so it's very reasonable that parents are going to be taking these medications while they're pregnant, while they're breastfeeding. And so it's really, really important that we have guidance and understanding of how they work, what are the recommendations, things like that. So methadone is the most is been around for a long time. So it's been around, I think, since the 1970s. It's considered an L2. Methadone is a medication that changes how the brain and nervous system respond to pain. It lessens symptoms of opioid withdrawal and blocks the effects of opioids and semi-synthetic opiates like oxy and hydrocodone. So again, it is an L2. It was an L3 for a couple of years, and then in Hale's most recent book, he bumped it down to an L2. It is important to observe the baby for sedation, dependence, and withdrawal symptoms. And methadone is just not used as much anymore, especially with medications like Suboxone. But what the recommendations are, and what the Academy of Breastfeeding Medicine says of when it comes to methadone, is that stable methadone, and this is a quote, stable methadone maintained women wishing to breastfeed should be encouraged to do so regardless of maternal methadone dose. In general, when it comes to all of these medications, the recommendations is that they breastfeed while they are receiving care. So if the parent is sober, engaged in treatment, health care, and prenatal care, and taking their medication as prescribed, then they should absolutely be encouraged to breastfeed. I saw Hale did a presentation last summer where he updated his guidelines on opioids. And what he actually said was he took it a step further, in that we actually need to extra encourage these parents to breastfeed. And that is because of the impacts that it can have on a baby, and the lessening of that baby's, of the neonatal abstinence syndrome, or the withdrawal symptoms that baby goes through. And so he really encourages us to go above and beyond to make sure that these parents breastfeed. And he even said, even if they don't want to breastfeed, try and get them to breastfeed for just 1 month. month, because that baby will be in such a better place if they get small doses or small exposure of, a buprenorphine or Subutex, Suboxone through the parent's milk for that first month. That's going to really lessen those withdrawal symptoms, which for anyone that has worked with babies who are withdrawing off of, whether that's recreational use or use of opioids or synthetic opioids, because these babies are dependent on them, that it's really hard on babies. And so being able to breastfeed is really helpful for those babies. And in fact, I've been working with several parents who are taking Suboxone to treat their opioid dependence, and so far, 100% of those babies have had no withdrawal symptoms because they've been breastfeeding, and so it's really exciting to see, and I hope that we can continue to encourage parents in this way. So Suboxone is an L3. Suboxone is the most common of buprenorphines that are used, and typically what most people are going to be using, despite Subutex being an L2. So Suboxone is just it's a preferred medication. So it's a buprenorphine. Suboxone does 4 things, and this is, some of the reasons why it's the most preferred. So the first thing it does is it binds to the brain's opioid receptors and satisfies the person's need for an opioid, which suppresses withdrawal symptoms and cravings. The second thing that it does is, because Suboxone incites the brain's receptors a little bit, it is a partial agonist. This means that if someone uses recreational opioids, they won't get that full effect of it. The third thing it does is that it sticks to the brain's receptors. So opioids have a really hard time attaching, and it remains that way for several days at a time. And then the last thing Suboxone does is that it has an upper limit on how much it lowers breathing, kind of like a ceiling. And so this makes overdose deaths much less likely. And so this is why Suboxone is kind of the preferred medication for treating opioid dependence. Again, is considered safe for pregnancy and considered safe while breastfeeding. And again, we really want to encourage these parents to breastfeed. Subutex or Buprenex is an L2. It's another buprenorphine, but Subutex is used for patients that can't tolerate the presence of naloxone, which is that agonist, opioid agonist, which occurs that's found in Suboxone. So that's kind of the reason why someone would maybe be offered Subutex. So that is that about those medications. I know it's more and more communities are seeing MAT programs or programs pop up where someone is getting treatment and getting prescribed these medications. And so it's just really important that we make sure these families are being served and getting what they need, and they need a breastfeed. So, want to breastfeed? All right. Gosh, I have 8 minutes, don't I?
Mhm.
Okay. All right. I'm gonna try and do this really quickly. Okay. Oh, thank you. All right. So next we're going to talk about some recreational substances. And I'll try and go through these really quickly because I'm guessing there might be 1 or 2 questions afterward, but I'll do my best to get through them. So the first thing we want to talk about is alcohol. And I guess the first thing I want to just acknowledge is that, our community, the Native community's unique relationship with alcohol. I know that this, sometimes this conversation can be difficult because the gist of it is that it's okay to breastfeed and drink alcohol. And that can sometimes be uncomfortable for our community members. Again, given the unique relationship we have with alcohol in our community. But I just want to acknowledge that Native people are perfectly capable of drinking alcohol normally. And it is okay. And so I just always want to acknowledge that before this conversation, because it can be for lack of a better word, triggering for some folks. But so we know that there's no known safe amount of alcohol during pregnancy. And when a person is no longer pregnant, is a whole different ballgame. So it's not the same. So people can consume alcohol without harming their infant. We do know that alcohol transfers readily into human milk. It is not stored in our milk though, so it enters our milk and exists in our milk just as it does in the blood. So, when we look at, think about our blood alcohol level, the levels of the alcohol is in our blood, it's in the same levels as it is in our milk. So it's actually an extremely low percentage. So thinking about most people are familiar with the quote legal driving limit, right? Which is 0.08. What that means is less than 0.1% of that person's blood is alcohol. And that's a fairly inebriated person, right? Someone that's feeling pretty tipsy or is drunk. So someone whose blood alcohol level is 0.08, that's how much of their milk would also have alcohol in it, which is less than 0.1%. So again, a very low amount of alcohol is actually getting into the milk, which is considered not dangerous for the baby. What we end up worrying about more as the parent drinks more is their ability to parent, less so about the exposure of the alcohol in the milk and the danger that poses to the baby. We also know that alcohol is readily and rapidly metabolized out of our system. So again, it is not stored in the milk. So it's not like we drink a beer and then we have alcohol milk until we pump that alcohol milk out. That's not how it is. That alcohol is rapidly metabolized out of the system, usually within 30 to 60 minutes, and it actually falls rapidly afterward. So this is why we do not recommend and would not recommend that someone pump and dump or anything like that, because again, that's just not the way the alcohol is in the milk. So there's no need to pump and dump. We would recommend that a parent still breastfeed and be able to comfortably have a few drinks or whatever that looks like for them. Again, once a parent is drunk or at that level, the concern is not so much the amount of alcohol that's in their milk. The concern is their ability to parent, and hopefully that baby is with a non-drunk adult who can take care of them, right? And then when the parent is feeling better and can parent again, then they can go ahead and nurse. So yeah. What we also know about alcohol is that, and something that is important for parents to understand, is that alcohol is a depressant. So that's the drug category that it's in, right? So it's a depressant, and it might make someone feel okay for a little bit, and then they're not going to feel that great, like afterward. And so one of the things it does is can inhibit the milk ejection reflex, which is that milk letdown, which remember oxytocin is our love hormone. That's what induces the milk ejection reflex. And so alcohol as a depressant kind of fights oxytocin, which is why we might see a reduction in that and reduce the milk flow. Parents reported or research shows that there's about a 25% reduction in milk release when alcohol is present in the milk. And in another study, alcohol completely blocked the release of oxytocin. And so this is especially important for parents that maybe are experiencing perinatal mood disorder, so depression or anxiety. Maybe they have a difficulty with that oxytocin release, have difficulty with their milk letting down, or someone who is making just enough milk or has a sensitive supply. A 25% reduction in their milk release can result in not enough food for their baby. And so, each individual person should be kind of talked to differently and be given this information, and they can make the decision for them on what's right. The American Academy of Pediatrics, their statement on alcohol use says that breastfeeding mothers and alcohol, or says about breastfeeding mothers and alcohol that the two are, quote, usually compatible. And then Dr. Jack Newman, who's a medical doctor and lactation expert based out of Canada says that prohibiting alcohol is another way we make life unnecessarily restrictive for breastfeeding mothers, which is true. We, as a society, have very high expectations for what lactating people should eat, drink, do, all of that kind of
Mhm.
stuff. And really, they're just people and should be able to do the things that all people do and can breastfeed while doing that. So that's what we know about alcohol. Next is marijuana. When it comes to marijuana, and I know we're like almost out of time, so I'm going to get through this one. And then just, real quick, non-ceremonial use of tobacco is okay. We just really need to be conscious of the exposure of second and third hand smoke to that baby, things like that. And then other recreational drugs in general are not considered safe while breastfeeding because we just don't know. We just don't know the risks. We have no research on them. So kind of to close out with marijuana, we know that, for Native people that report a lifetime substance abuse disorder, about 90% of them use marijuana. And currently about 4% of women report using drugs during pregnancy, and about 75% of that group reports using marijuana. So I have a feeling that this is much higher even than we know. And I know, in Washington state, we've had legalization for about a decade at this point. And so we definitely are seeing an increase in parents telling us that they're using marijuana in pregnancy. I don't think the numbers have actually gone up, or I suspect they haven't gone up. I just think that because it's not illegal and the stigma has been reduced, that more people are talking about it and sharing their marijuana use with providers. The active ingredient in cannabis is THC. And THC loves fat. It's concentrated in fat. And just so you know, the brain and the body, especially of a baby, is lots of fat. So this is something that's really important for people to know. This is why THC stays in our system for so long, because it binds and loves to live in fat. And so just an important piece of it. We know that, for marijuana use, that it is concentrated and stored in tissues for several weeks. And THC may produce changes to certain hormones, inhibiting prolactin, and prolactin is our milk making hormone, and growth hormones and thyroid stimulating hormone secretions. And so it does get into the system, and it does get into our milk, because remember, THC loves fat, milk is fatty, and then babies are fat. And so it does get into our milk, and it does get to the baby. It does not have psychotropic effects on a baby. So it's not like if someone, a baby is going to get high or anything like that off of breast milk, but a baby will test positive for marijuana. And this is something that is especially important for our Indigenous babies, for our Black relatives, where our babies are more likely to be drug tested at a hospital or in the medical system without our knowledge and without our consent. And while in many states, and I know Michigan has legalization too, right?
Mhm.
So in general, like, we turn our head, when it comes to adults testing positive for marijuana or using marijuana, because it is legal, but it is not legal for babies to use marijuana. And so it's one of those things that we just really want parents to know. We know that it is probably safe to use marijuana and breastfeed. Kind of what we know about it is we're saying it's probably safe. There's a massive lack of research out there still, and it's federal illegality really interferes with our ability to research it effectively. But what research has been done is saying that it is probably safe. However, again, our babies are more likely to be drug tested. And if our baby tests positive for marijuana, it will be a mandatory report to CPS. And so families really have to kind of be aware of that. And again, that may be a risk you're willing to take, and it also might be a risk you're not willing to take. And so we have to make sure parents have that information and they can make an informed decision on what they're comfortable with, right? They may feel like that's not a risk factor at all. there's no, that's not going to happen at my hospital. So I'm not worried about that. But we were in, White Mountain Apache last summer, and we learned there that at 1 year old, when those babies go to the clinic, they do mandatory screening for iron levels and things like that. And they drug test the babies routinely as part of that 1 year screen. And so that's done in an IHS facility on an Indian reservation. And so again, it's something that we need to consider. And I just really want parents to know. But Hale has changed his recommendations. Again, he used to say marijuana was an L5 because it was illegal, and he didn't want anything to interfere with the parent's ability to breastfeed, and being arrested would interfere with their ability to breastfeed. But so what he says now, and he's actually the one doing most of the research on this, and it's still fairly new because in Colorado and Washington, we've only had legalization for 10 years. And so this is pretty long-term research, right? So what he says is that we need to kind of take a harm reduction model. We want to advise to stop using, advise that it might lower supply because it does decrease prolactin, which is our milk making hormone. But we want to advise that they breastfeed, right? That there is very little THC in milk, and we don't think it causes a problem for a baby, or it's not likely to cause a problem for a baby. But he does say that heavy use with parents that mix feed should probably be discouraged from breastfeeding. This is a little trickier to suss out. And again, most of us are not going to actually be making these recommendations because it's not necessarily within our scope to do so. But, I have a feeling that Hale, from Texas, his definition of heavy use is probably a little bit different than my definition of heavy use, is like an old hippie and kind of thing. And so, heavy use is very relative and subjective to kind of like who is making that recommendation. But what he's saying here about mixed feeding is that we know that when a baby is mixed fed, that they just aren't getting the full protections of breastfeeding. And so I think that's kind of why he's making this recommendation that if they're being mixed fed, they should probably be discouraged from breastfeeding because they're not going to be getting those full protections from exclusive breastfeeding, and the exposure to THC in the milk may be riskier for them than if they were exclusively breastfeeding, getting those full protections. So those are the current recommendations as a whole when it comes to marijuana. Marijuana, I will say too, CBD, which is really common, that even topical use of CBD does transfer into milk. And again, a baby will still potentially test positive, and CBD is something that it's not properly, it's not regulated. I don't want to say properly, it's not regulated. And so even though some CBDs say there's no THC in it, there's actually no way to guarantee that. And so it's just things to consider. And again, kind of more use, personal opinion of why federal legalization would be really important, so that we can actually research these things and know them and be able to share factual information for people, instead of we're just kind of like trying to figure it out and make guesses and things like that.
So that includes the CBD topical lotions, things you
Yeah.
see for like pain.
Yes.
Yeah.
Yep. Yeah. Like I said, with because I know I'm over, but just a quick overview for non-ceremonial tobacco use. Nicotine is an L2, so considered safe. And those that smoke cigarettes or use tobacco, non-ceremonial tobacco, that we really want those babies to be breastfed. So it does put them at risk, particularly of SIDS and ongoing respiratory issues and asthma, things like that. And breastfeeding offers significant protections for those babies. And so we really want to encourage those parents to smoke or to
Not
to
to
breastfeed.
smoke and breastfeed.
So sorry. We want to encourage them to breastfeed if they're smoking.
Yes.
All right. And so, yeah, just here's a little bit on reducing that harm reduction model, what we want to talk to about parents. I personally am at a point when it comes to, because I think here we have co-sleeping, is best not to smoke within 40 to 60 minutes before coming to bed. And I typically do not recommend that a baby bed share with anybody that smokes cigarettes. And so that's something also to keep in mind. And then again, like I said, with those additional recreational drugs, that the current recommendations are that if the parent is using recreational drugs, that they should not breastfeed. We have very little research. And so because of that, the recommendations are really conservative, but considered reasonable, considered the current evidence. And so I think that is
That's
it.
it. There's one more question.
I
What
know.
about NRT
I
and
don't know
breastfeeding?
what's NRT.
I don't know what
It's
NRT is.
nicotine replacement therapy.
Oh,
So
okay.
it's just
Like
nicotine,
vaping.
gum patches, sprays,
Yeah.
inhalers, lozenges, but not other,
Yeah.
not like the other harmful chemicals in tobacco.
Yeah. So, okay. Thank you. Thank you for that question, Ryan. It's good to see you. I see your name, but yeah, in general, those would be considered safe with breastfeeding. Again, they
It's more than
the
nicotine.
smoke, second and third hand smoke is what poses the most risk for a baby. And so we would want a parent that's using a nicotine replacement therapy, whatever that is. We would say good job, encourage them to breastfeed, and in general, it would not be posing a risk or a significant risk to a baby.
I have a quick question.
Yes.
Or maybe it's more of a commentary. Maybe it's a question. You had mentioned about ceremonial use of tobacco.
Mhm.
And so I know like the target audience for these webinars is, healthcare workers, healthcare providers. And I'm curious if there's a way for, I don't know if healthcare providers are required to say you can't smoke or if you're smoking, then you can't breastfeed. I don't know if that's something that
I don't think so.
Okay.
Yeah, in general, I don't think so.
Okay. So I'm just curious if there's ways that they can, or advice or suggestions for folks on how to make parents feel a little bit more comfortable in talking about those things if they want to. Because I know, especially in our communities, because our communities are heavily, we have a long and dark history of our babies being taken from us. And, you had just talked about that, about them being tested, babies, brown and black babies being tested without permission. So there's probably also a lot of parents that are like, on these forms, or when the home visitor asks us, do you smoke, that we're like,
no,
no, right?
Yes,
Because we are afraid of our babies. And so I just was wondering if there's any advice for maybe for the healthcare providers and how they can kind of make that more comfortable for the for the parents without them being afraid of having their babies taken.
Totally. Yeah. I mean, I think that for providers in that way, and it's it is hard, like, and I get it, and parents are really, really scared. And so for providers, it is in your best interest to provide non-judgmental support to families, right? Because you will have families that do not disclose being, whether it's like substance misuse, recreational, whatever that is, which can impact your patient, right? And it's better, the more we know about our families and what they're doing or what they're taking, the better you can serve them. And so being able to provide that non-judgmental, open support with them is important. And making sure that they know that, and then word will get around too, right? In the community of like, oh, this doctor's real cool, like they're open with me, and they're gonna understand if you come to them, or if they come to you and disclose something to you, the way you respond will have a ripple effect in that community, right? So you respond punitively, you respond in a judgmental way, you respond in a way that makes that family feel unsafe, then word will spread, and less people are going to talk to you, see you, things like that, where it word spreads in the other way of like, oh, I talked to them about my peyote,
Mhm.
using peyote in ceremony, and the doctor was really cool and kind of understood and actually asked me about it
Mhm.
and did, whatever,
Mhm.
right? And that means something to a family. And so, yeah, I think
And
like,
like in that situation, they would also continue seeing seeking healthcare,
yes,
whereas somebody
yes,
else that gets judged is just
never,
like,
They're
I'm
gonna stop
done. I'm
going to
not
never,
their
going
doctor
go to the doctor
appointments. Yep.
for their
Yep.
own.
yes,
That has nothing to do with any of this, you
yes,
know.
yes,
I got a pain in my side and I can't
Yeah.
breathe, that they're gonna be like, it's not safe to go to the doctor. I'm just going.
absolutely,
Yeah.
absolutely. Yeah. So yeah, we definitely as healthcare providers have to do better there.
Mhm.
And that's what, I do think like, not to get all political, but legalization helps to reduce that
Hmm.
stigma, right?
Yeah.
More people. I mean, I went from having folks in Seattle and breastfeeding classes kind of ask me super on the down low
Yep.
about marijuana, like they'd hang back until everybody left the
Mhm.
class
Yep.
and be like, hey, is it okay if I
Yep.
smoke, I smoke weed for my appetite, or whatever that is, like, is that okay? To now they're like hand raised in a class of 20 people, like,
Mhm.
so I smoke weed, like, is that cool?
Mhm.
Mhm.
That kind of thing.
Yeah.
Like, it's legalization has really reduced that stigma. And so I think, as nationally, like, I hope that we continue to move in that direction, because it just benefits us all to be able to talk about it
Yeah.
openly,
Yep.
Yep.
right?
Openly, safely, and give,
Yes.
good patient care.
Informed,
Informed. Yep.
evidence-based advice,
Yeah.
and when we don't know, we don't know. I mean, I wish we could say straight up, like, marijuana is safe, it has no, like, it's no
Mhm.
problem. It probably is, but we don't know that. We can't say that emphatically. We don't have the research. We don't have the studies, things like that. But what we do know is that it's probably safe, and hopefully we'll just gain more and more information,
Mhm.
things like that. But, again, we need to give parents the information they need to make an informed decision, and each parent is going to have a different comfort level, and
Yep.
that's
Yep.
what, in the end, that's what we have to do. It's not up to us to tell them what to do or not to do. And healthcare providers are the same way.
Yeah.
It's
Yeah.
your job to provide evidence-based, compassionate information to a family, and support them where they're at, and what they're going to be doing. So yeah.
Awesome. Well, it doesn't look like there's any other questions or anything in the chat. Is there anything in the Q&A? I think that comes up in a different
Yeah.
box. Doesn't look
Doesn't
like
look
it.
like it.
Okay,
Yeah.
Good to
awesome.
see you. I see Cedar on there
Yeah.
too. Hi,
Hello.
Cedar.
Hi, ladies. I see a few. Yep.
Yep. And others that are here. So good to see you all.
Lots of people on from all over Michigan and
Mhm.
Minnesota, looks like. So awesome. Good to see everybody here. Thank you so much for joining us. Um, Again, this is a series of webinars that we're recording over the next couple days. So please join us for any of the rest of them if you are so interested, and if you know other folks that could benefit from this information, please feel free to share with them the Nooni Project's website, nooniproject.com, where they can register for the webinars. And yeah, awesome. So again, thank you, Cami and Kim, for all your wonderful knowledge. It's always helpful. And like I said, I always learn something every time. So thank you so
Northern
much.
BC.
Yeah.
And
Canada's in the house.
ooh, nice. I like it. I just went to British Columbia in May for the
Yeah.
first time.
Yeah.
And it is, I'm telling you, the most beautiful place I've been in the world. And I'm super down for Michigan. Like every time
Yeah.
I always tell people, wherever you live doesn't compare to Michigan.
Yeah.
Right.
I would, I would die on that hill. But then I went to BC and I was like, just kidding. This might be the spot. Anyway,
Oh,
thanks for
yeah.
joining us.
Yeah,
Thank
from
you.
BC. And I don't know if your name's pronounced Talia. That's how I want to pronounce it. But Kim and I did book our first training in Canada. So we're gonna be in
Yeah.
BC in Kamloops in
In
February of 2023. So there'll be more information to come about that. But we're really excited to go to Canada.
Yeah.
So yeah. Anyway,
Awesome.
going
Well,
international.
yes, finally.
All
Well,
right.
thanks everyone. And
All
thanks
right.
to
Thank
Mark
you.
helping
Thanks,
us
Mark.
behind the scenes. And popping in with his commentary every now and then. We love it. The immediate whoa.
Hey,
You're learning so much.
you guys made fun of me with the anesthesia comment.
I like it.
And then later you looked on the screen and said, well, those I can't really pronounce those.
No, I would don't worry.
All right. Thank you, everyone.
All right.
see you
Thank
again.
you. See
Bye.
you
Thank you
soon.
for joining us.
Chaksha.
Bye, Mapi.